Thank you very much. The next speaker was worried about a visa problem from the 51st state. He wasn't sure he would be able to return to the other 50 states. But we have a video, is that correct, Morale? So Juan-Pablo Umana, there he is, hola.
Interesting case of a 43-year-old male who, as he was caring for a friend's pet rescue, underwent multiple scratches on his arms and hands, and presented to the ED with a swollen erythematous wrist, was treated with tetanus and rabies vaccines and DC'd home on antibiotics, but 24 hours later presented septic, febrile, and disoriented with a joint aspiration that grew coag-negative staph A. An echocardiogram performed because of a murmur found during physical examination showed what was suggestive of a bicuspid aortic valve and an abscess at the level of the aortomitral curtain. Collar Doppler confirmed the presence of a fistula between the aortic root and the left atrium, as well as severe AI secondary to destruction of the aortic valve. A bicommissural view on the echocardiogram showed what appeared to be involvement of the anterior leaflet of the mitral valve by endocarditis. Our operative strategy was then to perform a radical debridement, then restore valve function by implanting a homograft and the cardiac integrity by reconstruction with pericardial patch in order to avoid as much foreign bodies as possible. With this, of course, what we aim to achieve is drainage of the abscess into the pericardium. Intraoperatively, we found a left-right fusion of the bicuspid valve with extensive involvement of the non-coronary sinus and the non-coronary cusp. It's very important to perform an extensive assessment in these cases in order to see things like this, where you find fistulous tracts into the right atrium before starting the debridement. We then performed an extensive debridement of the non-coronary sinus, resecting the non-coronary leaflet, but opening into the right atrium, as you can see there, in order to get rid of the infection. We scraped some of the vegetations of the base of the anterior leaflet of the mitral valve, but then had to go on and continue opening the base of the heart into the left atrium. We fashioned the coronary buttons, resected some more vegetations off of the roof of the left atrium, and required some additional resection of atrial tissue. We then excised the infected portions of the anterior leaflet of the mitral valve from trigone to trigone, as you can see here, but we're able to preserve most of the chordae in order to reconstruct it later. Once we were happy with the debridement, we inspected the rest of the mitral valve, finding that the posterior leaflet was free of infection with a normal mitral valve annulus. At that point, we proceeded to estimate the size of the neo-LVOT, started the reconstruction of the interatrial septum, followed by the implantation of the homograft and reconstruction of the anterior mitral valve leaflet using the homograft leaflet. After marking the trigones on the homograft, we started the reconstruction of the anterior leaflet of the mitral valve in the middle, running the sutures from there up into the trigones. We then implanted the homograft again from trigone to trigone with running proline, and avoided using any additional material such as Dacron felt in order to try to eradicate the infection and facilitate its treatment post-operatively with antibiotics. Once that portion of the implantation had been completed, we started the reconstruction of the roof of the left atrium with a patch of Dacron that you can see there, and proceeded to complete that portion of the reconstruction by suturing the posterior portion of the homograft to the patch. Suture was tightened in order to avoid or prevent any bleeding from that posterior portion of the operation. The coronary buttons were then re-implanted with a running 5-0. We completed the reconstruction of the intraatrial septum and closed the right atrium before performing the distal anastomosis from the homograft to the distal aorta, de-airing the heart, and completing the operation. The key takeaway points from this case then, and for every one of these cases, is to perform as extensive a debridement as possible, to then go on to perform the mitral valve reconstruction, either with an annuloplasty ring if needed, or as in this case, just by reconstructing the anterior leaflet of the mitral valve using the anterior leaflet of the mitral valve homograft. The LVOT reconstruction then follows to end with the reconstruction of the left atrium as we just showed. Again, I want to thank you very much for the opportunity to be here virtually, and hope you guys have a wonderful time in Toronto, and see you again soon. Thank you very much.